Next, we have Jody Jolamore. Jody Jolamore is a gay men's health research and consultant who currently works as the Director of Policy for the Community-Based Research Center in Vancouver. His work includes the SOCUP of HIV prevention initiatives for gay, bisexual, two-spirit, and other men who have sex with men across the province. Prior to consulting, Jody was the Director, Research Strategic Partnership at the gay men's health organization, Health Initiative for Men. A Pan-Canadian with a Master's in Public Policy from SFU, he currently lives in Vancouver's beautiful West End. Welcome, Jody.
So I've got the afternoon fatigue from lunch, so I just want to invite anybody else who feels that way to stand up for just 15 seconds if you want to. Stretch your legs for a second. I'm feeling it, and I'm nervous being up here, so I can only imagine what you guys are feeling sitting in the audience. Stretch it out. Let's get rid of this. Thanks. We do have a break after this, so everyone will get 15 minutes to have a coffee and a little break. Thanks for coming to our session this afternoon. I just wanted to say, Ellen, it's really great to see that work. I remember when I was working at Health Initiative for Men, we purposely promoted that study and said we want LGBT representation in there. So it's great to see that it's reflected. And also, I think you've got some really cool infographics on the website, so do check it out. It's a really I think it's an excellent example of knowledge translation. So thanks for that. My presentation is more so an update on the work that I've been doing over the last year and a half. So I'm going to start the presentation by positioning the work. For some of you, that will be repetitive because I know some of you have sat through this presentation with me before, but then I'm also going to do an update on what I've been up to more recently, which may be newer information, and then also some forward thinking. But please, I know we're going to move into questions after this, but you can feel free to interrupt me or ask me questions throughout because I think I've only got about a 15-minute presentation. So to start off with a note on language, I use the word gay man because that's the way I've identified since I was about 18 years old. I was a bisexual for a brief period of time before that, when I'm talking about gay men, I actually, the men that we're working with are men who have sex with men, and that includes gay, bisexual, queer, two-spirit, including trans men. So I like to note that at the beginning of the presentation. So why are we doing this work? So these are my little friends. And I put them up there. I mean, obviously somebody dressed them in those clothes, but still I think it's a powerful visual representation of some of the messages of hate that we've seen recently in America, and there's certainly worries that that will become more commonplace. So GBMSM health outcomes. So trauma experienced through bullying, harassment, and violence leads to stigma and shame, and that's why we have an entire conference about it. We've got higher rates of attempted suicide, substance use, and abuse, smoking, partner violence, and of course STIs and HIV. This slide is about a year outdated now. We're waiting on the new data, but that top line, of course, is MSM, or gay, bisexual, GBMSM, and of course we continue to be disproportionately impacted by the burden in British Columbia and many other places in Canada and Western nations. There's some theories behind this. Ron Stahl has a theory on syndemics, which if you've been to the summit before, you've almost certainly heard about syndemic theory. But essentially, there are a number of epidemics that are going on in our community. Many of them I talked about, or I showed you on the slide at the beginning. But essentially, these are coming together to lead to the health outcomes that we experience in our community. And really what Ron Stahl says is that you can't fight one without fighting them all, right? If you just concentrate on STIs and HIV, you're missing the relationship between sexual health and mental health, so you really have to work on mental health. And we know that body image and appearance and shaming can feed into mental health, so it's all connected, and that's how we really need to be thinking about this work. So maybe it's not homosexuality, maybe it's homophobia. So this again is taken from Ron Stahl's theory, which is that young GBMSM experience violence, it's commonplace, and that this victimization predicts poor health outcomes in the general population, including our population. The experience of homophobic attacks make the importance of resilience in social networks that much more important. So I say this, and I realize this may be repetitive for a lot of you, but I'm trying to ground this, this is why we're doing this work. And so what do we know about some of those protective factors? Well, we know that gay men have a sense of coherence because we tend to develop community a little better than some of our other populations. We have good social support and self-efficacy networks, and our social network sizes are larger, which I think Ellen talked about as well. We make our own families, and that ends up being a huge resiliency factor for us. But we know that outside of urban centers, that's a lot more difficult. Your family gets a lot tinier when you live in some of the smaller communities across British Columbia. So I threw these up here because I don't want it to sound like all of these factors are coming from the outside. If you go online and you look at social and sexual networking profiles, you'll see things like clean, which of course is a word to describe somebody who at least perceives themselves as not having HIV or STIs. And this is language that we're using against ourselves as gay men. Here's another one, mask for mask, which is something that we hear commonly in profiles. And by the way, these are not real people, so don't. I see some people like, oh, do I know Brad? No, you don't. Well, you may, but so the whole notion of GBMSM, and I think that's what this summit is starting to talk about. Last year, we really talked about the external forces that were impacting us. This year, we're starting to talk about a lot more of the isms that we have within our community. So we also have a lot of strengths, particularly in British Columbia. So I do a lot of traveling to talk about the work we're doing, and we are the envy of most Canadian jurisdictions and certainly British Columbia jurisdictions. We've got it pretty good here in Vancouver. We have a very supportive health authority in Vancouver Coastal Health. We have a history of innovative community health and commitment to harm reduction. We've got an organization like the Health Initiative for Men, which does targeted, tailored programming. We've got some dedicated funding. The Stop HIV and From Home, I'm sorry, that's a typo, From Hope to Health strategy, of course, helped to provide funding that enabled us to start new projects and also sustain other ones. Policy and strategy, the Provincial Health Officers Report, which I'm going to talk more about in the rest of the presentation, has really provided us with a strategic and policy framework that we can go to decision makers with that report, with data like Ellen's, with data that comes out of the Sex Now survey, and make a case for why we need to be investing in GBMSM health. And then, of course, there's an abundance of research and surveillance that's going on right now. ManCount was a study that's a few years old now, but the semi-annual Sex Now survey. Momentum is just about to enroll a second cohort. We heard some about the Momentum study today. And of course, Engage is a national study that will see Momentum replicated in Toronto and Montreal so that we can compare across those three cities. So now I'm going to give a bit of a just background on what my position, how my position came to be. So of course, Stop HIV was initially a $48 million pilot project for Vancouver and Prince George. And after some advocacy from some people in this room, we were able to expand the vision of Stop HIV to include GBMSM because actually we weren't even mentioned in the original document for planning. So because of that, funding went to improving both systematic changes in HIV, but also some targeted programs for improving testing rates, support, connecting people to ARV and adherence. And this provided a backbone for funding for us here in Vancouver, but Vancouver Coastal was often, or was fairly well funded in that sense previously, but it also provided some funding that would be extended outside of Vancouver Coastal after the pilot in Vancouver ended. So $20 million is now the annual budget of STOP, and it's distributed among the 6 health authorities if you include the First Nations Health Authority. So this pot of money, the STOP funding, was directed by a steering committee, provincial steering committee, and they created a collaborative implementation committee, and the collaborative implementation committee created working groups, and one of those working groups was the HIV and Gay Men Working Group. And that's the working group that essentially supervised my work for the first year that I was doing it. So the Gay Men's Working Group consisted of individuals from the health authorities, so the STOP leads, as well as community, the Pacific AIDS Network, Health Initiative for Men sat at that table, and they decided, well, actually with direction from the CIC, so I know this is getting complicated, steering committee, CIC, working group. Working group took direction from the CIC, which said, we want you to make one of your 4 strategic priorities the implementation of the PHO report. So they asked the health authorities to contribute some funds, and they did. And so for 1 year, they hired me. A couple of caveats to that. So I was part-time for the first year because it was really an opportunity for us to consult, to build a plan, and to put some of the strategic framework in place. Since then, the Provincial Health Services Authority created a funding, an RFP process where they created some funding to do this work. This is extremely rare, and I feel so honored and privileged to be able to do this work because there aren't many people out there who are getting paid to think about gay men and gay men's health at a strategic and policy level. Most of us who are doing this work are doing frontline work. We're testing people, we're creating supports, we're doing ARV adherence, we're maybe doing social marketing campaigns, but not many of us can sit down and say, okay, what's the big picture? Where are we connecting the dots? We've got a gap over here, and I've had the luxury of doing that for 1.5 years, and I really feel privileged, and I think it's testament to some vision that happened in our community and both at a government level as well. So like I got goosebumps talking about it, actually. I feel really excited about this work. So, so they put together some funds and they hired me to do this consulting work for the first year, and then afterwards they awarded the contract to the Community-Based Research Center, the organization that's hosting the summit. And now, of course, the Community-Based Research Center has integrated my work as the network director into their other programming. So all along, the summit and the Sex Now survey were going to be major tools that we were going to leverage as part of the network, so it really makes sense that my position is housed at the CBRC. So what are the PHO priorities? So the report, if you haven't read it, I recommend you do. It's a couple years old now, but it's still very relevant. It lists 6 strategic priorities. And these are fairly high-level priorities. If you read the language, they are about making schools healthier, a little more detailed than that. But there's not necessarily an action plan or many recommended activities to attach to that. So that was my role the first year of the project, was to build an action plan or a list of recommended activities to try to deliver some quick wins along the way if we could. And by quick wins, I mean we knew that we could deliver some cultural competency courses fairly quickly. We didn't need a lot of prep time for that. We knew that we could introduce some players who just hadn't been speaking before and create a connection and get some synergy going. And then we also want to affect long-term change. And then the second goal, or the second major objective, is to develop a GBMSM health network. So the approach in the beginning was to visit the regions, and it still is, to keep a healthy relationship with the STOP team, because they're the individuals in the health authorities who actually have the purse strings and who can actually fund some programs. Because another important piece about my work is that it really is only for an FTE and a travel budget. So the network is not funded to do any activities yet. We don't have a programming budget or a service budget. It's me. I'm the network, and I get a travel budget, which enables me to visit the regions, but it also enables me to bring some players together for regional meetings. For instance, there are a couple of people in this room that have been sponsored to come here as part of the network because we're trying to build capacity in other places like Prince George and Kelowna. And so that's been a major part of the job. Making recommendations where we see that they need to be engaging decision makers, influencing change, and then using those priorities to stimulate dialogue. So year 1, 2015 to 2016, I began the work part-time in the summer of 2015. And over the course of the year, I've been able to engage more than 200 stakeholders in all 5 health authorities. We've identified strengths and gaps. We've done some capacity building, some information and best practice sharing. Lots of networking and network building, knowledge transfer and exchange, and it's enabled me now to start to put some of the action plan, which I'll talk about shortly, into play. And then, of course, cultural competency courses for nurses and healthcare providers, and we've done that in a number of places in British Columbia and as well for the CANAC team in Halifax. And so I guess I just wanted to take a break from the plan to bring us back to reality. So why are we doing this work? So through my consultation, I'm working in one of the health authorities, and I get the privilege of interviewing a nurse and a newly diagnosed individual, and separately. And it was actually just coincidental that I even got to interview them both. So it was serendipitous in some ways. And I spoke to the nurse first, and I remember she really struggled with the idea of anonymous sex. She really struggled with the idea of not knowing one's sexual partner, and she pressed me on this, and she felt that perhaps there was like a boys' club, and we were lying to her, and that actually we all know our sexual partners, and I had to explain to her some of the mechanics of gay sex, and then I got to speak to the newly diagnosed individual, and he talked about feeling harassed and shamed. And he said to me, Jody, I know where I contracted this. It was in a bathhouse, and I definitely do not know who gave it to me, and I'm not hiding that from her. That's the truth. And that reminded me that this was a nurse who was hired specifically to do HIV outreach work, and clearly did not understand the mechanics of gay sex. So it's just sort of testament to why we need to constantly be doing cultural competency work, not just with nurses, but with healthcare providers, with service providers across the province, across Canada. And that's our job as gay men, to be constant. Even if you're not paid to do that, I think that's something that we need to do for our community and for others, is to be informing our healthcare providers about the things that are important to our community, because hopefully you leave them better than you found them. And some additional feedback, which I thought was really interesting, and I throw it in here, was he was talking about operating hours. And this was a gentleman who worked in blue-collar work. He was not out at his work. He was certainly not out about being HIV positive. He could not access a healthcare appointment outside of work hours. So he's constantly now going to his boss and having to explain why he needs to go to the hospital for blood work, why he needs to go meet his pharmacist to get ARVs, why all of these things are offered at a 9 to 5. So we've got to be thinking about those things as well when we're program planning. So this is the kind of stuff that I got to hear about over that year, and it's really helped to inform my direction and my thinking. So this is the result. We come up with things like this. This is actually a slide that is put together from a number of questions that VCH developed a continuing medical education course that they've been delivering to physicians who are interested in engaging their GBMSM patients. And so this is some of the stuff that we walk them through. And this is some of this is in the CME course, but some of this is, I deliver this when I'm doing workshops with nurses or community groups. And it's just to get them thinking a little bit more about the mechanics of gay sex and relationships, and asking questions less about orientation and more about, simply, do you have sex with men, women, or both? That opens an opportunity for discussion there. So year one, we drafted and consulted a list of recommended actions, and that's a 40-plus list. We drafted and consulted on a GBMSM network charter, and the charter is sort of the memorandum of the network as it evolves. There are 3 main activities that the network will undertake: knowledge exchange and transfer, cultural competency work, and strategic planning and advocacy. I would like to extend this invite to anyone here who would like to be put on the mailing list for the network. We're not a spam network. We'll be sending out only when events are taking place. We'll be having 8 webinars a year. 4 of them will be for healthcare providers. 4 of them will be for community members. They'll be across the province. The idea is to increase capacity around things like PrEP and targeted testing and other things that we know are pertinent to gay men's health. So I would invite you to join us. We had a consultation in March and an inaugural meeting where more than 30 stakeholders came, and again, we were able to use some of those network funds to bring people from the regions. I have attended numerous provincial gay men's health dialogue and events in Victoria, in Kelowna, and Totally Outright this year, which is a Health Initiative for Men project. And to me, this is a kind of an example of really the work, like this is a tangible example of the work I'm doing. Totally Outright is a youth program that Health Initiative for Men offers. The Men's Health Initiative in Kelowna is a great program that's attached to Living Positive Resource Center, and they're doing some great things with gay guys in Kelowna right now. So we partnered up with them, and the coordinator brought 5 youth from Kelowna to Totally Outright. And so Totally Outright is a capacity building course. So immediately we've sent like a small group of volunteers back to Kelowna who will hopefully stay engaged in the Men's Health Initiative, who will stay engaged in this work, and meanwhile building that capacity across the province. So year 2, which is what we just started this summer, so we're creating 3 working groups because there's already an HIV and gay men working group. There'll be a research, a safer schools, and a mental health and substance use working group. We're looking at some education support tools and curriculum consultation. So we know that part of that Safer Schools mandate is that teachers just don't feel comfortable talking about sex. And they need the appropriate resources and tools to be able to do that, to feel more comfortable, to know where to refer their queer students. And so we want to be able to do that. We're going to partner up with YouthCo. We're going to find some funding for them, and we hope to develop those tools. We're also doing curriculum consultation. So in British Columbia, most sex ed is actually not even delivered by teachers. It's delivered by third-party agencies like YouthCo, like Island Sexual Health, like Options for Sexual Health. So we're going to meet with them individually, and we're going to make the case for why they need to focus on GBMSM health and safer sex for gay men in their curriculum, and try to convince them to either enhance that part of their curriculum or adapt it. We're also working on continued cultural competency with VCH. Elizabeth Holliday is taking the lead in scaling up the VCH CME course to other places in the province. We want to make that a web-based module, and we're also looking at adapting it so that all healthcare providers in the province can access it, not just physicians. We're looking at a provincial combination prevention campaign. So right now I'm in the process of bringing all of our different partners together with some end-of-year funding, and I'm making the case for why we need to do a combo prevention campaign in 2017. That'll be for outside of Vancouver, but also will cover Vancouver. And then we're looking at the scale up of services like Totally Outright, Get Checked Online, Empowerment North. So I sit on a number of those committees. Empowerment North is, I think I'll close with that. It's an example of, again, another example of the work I'm doing. So I spent enough time in Prince George that I've been able to identify the funders up there. I've been able to identify a couple of community members who are interested in volunteering. We have some interest with YouthCo to pair up and do a program. So essentially, I've connected a group of potential volunteers with YouthCo who are interested in doing some provincial work, as well as Positive Living North. They're going to be the host in Prince George, and we're hoping Shiro Panessa is going to give them a little bit of money to get the program off the ground. And essentially, I get to connect the dots and then step away from the project. And YouthCo will supervise along with Positive Living, and that's one of the examples of sort of the work we're doing around facilitation. So I'm going to end with Todd officially. If you haven't seen the slide before, Todd Schmee is one of my heroes that keeps me doing this work on a regular basis. Todd is from Castlegar. And we had just finished a long consultation in Kamloops and Nelson, and we were on our way to Kelowna, and we stopped in Castlegar. We weren't speaking to anybody in Castlegar. We just wanted to grab a coffee, and we heard a very homosexual voice in the coffee shop long before we saw Todd. And he came out, and immediately I was like, "What the hell is this gay dude doing in Castlegar? Like he's obviously gay and unabashedly gay and proud of it." And so we immediately started talking to him, and we told him about the work we were doing. And he told us that he had lived in Vancouver and he had lived in Calgary, but Castlegar was his home. And that's where he felt most comfortable and most safe, and that's where he wanted to be. And I thought, wow, that's the reason we're doing this work. Because we know that not everyone is cut out for big city living and life. And so if we can create an environment or a society where gay men can stay in their communities and feel like they can have a safe school and they can access health care and they can have a doctor that understands their sexuality, then I think that's kind of my goal for the next 2.5 years. So you'll hear from me again next year on an update on all of this, but that's where we're at.
Thank you, Jody. I think we have about 5 minutes for questions. We have 2 microphones on either side of the hall. If anybody has any questions, feel free to voice them out.
Hi, I have a question for Ellen. Yeah. I was wondering if you'd comment on the study's decision to exclude queer and two-spirit identities as survey populations.
No, that's a great question, and it's something that we're going to do this survey again, and we are advocating to expand the different sexual identities and gender identities on the survey, because you're right, there is a gap right now in the identities that we are able to put on there. I think they were trying to be consistent with some other cross-national surveys or some surveys in other, like in the States, and I think we know that is a gap right now. So just
Thank you.
trying to stay consistent, but we know that we need to move ahead.
Great, thank you.
Thanks.
Thank you. Anybody else? We should have time for one more question, if anybody has.
This is also for Ellen. That's just really interesting data. And what I'm wondering about, you've finally solved what we were calling the denominator problem. How many? What's the denominator of the equations for how much people are being served? So 130,000 in Vancouver is what I'm hearing from you, and I'm just wondering how that divides between men and women.
No, that's a great question. I don't think we've solved the denominator problem. I'm going to start there. I actually think Mark is solving the denominator problem better than we are with some really interesting modeling work. Well, of the 133,000, about it's mostly men. I want to get you the number, so I might have to get back to you, but I know that it is more than half. Because when we do break down, for example, male respondents, we know that 5.8% identified as gay and 2.2% bisexual. And when we compare that to female respondents, it was about 1.2% gay, lesbian, excuse me, and around 2% bisexual. So it does seem like with our LGBT representation that it is a majority male representation. But let me get you those exact distributions.
Wayne, there is a population estimates paper that has just been submitted, but the preliminary work has been done, and it was actually presented at the PAN conference a week or two ago. And a team from PHSA was funded to look at that denominator question and try to determine who are we talking about? And they actually broke it down by health authority. The only one that stands out in my mind is Northern Health, because that's where I've been working. But the denominator there was they figured 2,200 gay men, or 2,200 GBMSM in Northern Health, and they figured that's underestimated by about 30 to 40%. Right. But that's their best approximation. And I don't remember the exact number in. Mark, have you seen the paper? I don't remember the exact number for Vancouver, but I feel like it was between 20 and 40,000 was the error or the margins, and they had an actual estimate in there. I'll forward it to you.
Sure, great, thanks.
That's much better resources right now.
It's a long ways from the days when it was the range was 20,000 to 160,000. So
yeah, we've narrowed it a bit.
All right, thank you. We might have time for one more if anybody has. Yeah.
I want to ask Eddie a question. So in your study, were you able to also get information about the sexual practices of the men? Like whether they're top or versatile or bottom, or does it relate to their anxiety level or how they perceive the aging process? And
I do have.
Or body types and, you know.
I have that information. I didn't do the analysis, but I might.
Might be interesting.
I agree, Alan. I think that would be interesting.
All right. I think if that's it, then thank you, Ellen, Ed, Eddie, and Jody, our panel today, tongue twister for the day. We are having a break for half an hour, and then we'll be doing another keynote presentation and the call. So thank you, everybody.